konuşurken off kanalını kullanacaksınız eğer soru falan yöneltecek olursanız. Dinlerken de çevrili dinlemek istiyorsanız German kanalını seçeceksiniz. Doğrudan dinlemek isterseniz de İngiliz kanalı seçebilirsiniz. Ama çevrili dinlemek isterseniz German kanalını kullanmanız gerekecek, Almanca kanalı. Sorularınızı da chat ekranında sorabilirsiniz. Toplantının sonunda sorularınız toplanacak, konuşmacılara teker teker yöneltilecektir. Ben şimdi sözü Profesör Chung'a bırakmak istiyorum. Lütfen Profesör Chung.
Thank you very much, Professor Bayram. I'm very pleased to chair this session, and in fact, I was very pleased when Professor Bayram contacted me a couple of weeks ago, asking me whether we could get some of our Chinese colleagues to talk about the experience of this new disease called COVID-19. Obviously, COVID-19 now is affecting most of the world. It has caused, well, nearly 200,000 deaths in the world, and it's affecting a huge number of people. So it's concerning every country in the world. But the first country where this infection started was obviously in Wuhan, China. And it seems very fitting that we obtain the experience of the Chinese people who've been fighting this virus. And it is a great pleasure that we've been able to assemble 3 of those doctors who've been fighting at the front line. And we are very pleased that they've agreed to share their experience with us, and particularly with our Turkish colleagues and friends. So we have a team of 3 speakers, so Professor Chung, Professor Chen, and Dr. Hui. And I'd like to kick off this meeting by inviting Professor Chung to give his presentation. So Professor Chung is a professor at in the State Key Lab in of respiratory disease, and also the head of the Guangzhou Institute of Respiratory Health. And Professor Chung, in fact, has great experience of fighting coronavirus, as he was the main manager of the SARS epidemic in China in 2003-2004. So, and he has now also been at the forefront of fighting the corona 2 COVID-19 disease in China when it started in Wuhan way back in December, January of this year. So it gives great pleasure for me to ask Professor Chung to give his presentation.
Okay, well, thank you very much, Ben and Marsan, and of course my colleagues Christopher and Rung Chang. So it's a great pleasure to have to be able to talk with my Turkish colleagues in terms of the control of COVID-19 infection. So I just waiting for the PPT coming out. Yeah. Well, Fan, can you see the PPT?
Yes, yes, you can.
Right. Okay. Okay. Well, I think that this picture is taken last night, so that the data about globally about 2.6 million, more than 2.6 million people being infected, with a mortality of 6.92%. And here in China, so the total confirms 84,000, and then mortality for 5.5%. So first of all, I would like to just give a brief introduction about China's strategy in combating further spreading. So I think it started so with the executive committee, including Professor Yun, so Christopher, good friends, and then we went to Wuhan on the day 19th of January, and then we conclude there had been announced there's a definite human-to-human transmission, and also confirmed that the medical staff have been infected. Actually, before that, so we had already had some news from that. So since then, I think there will be some action coming from China. So I took this model and showing how what control measures can reduce spread of the virus in the UK. And here's the model, some spring, summer, and autumn. So new cases. So if you take any action at all, so the curve, something like that. And then if you take some action, like what kind of action? Control measures, self-isolation if ill, and social distancing. So for vulnerable, and whole household isolation if one member is ill. So that's they suppose the curve will be under the level of a national health system capacity, which is very important for all the countries. So if loss of control, in particular, so exceed the capacity, so they will cause a lot of things, even disaster. So based on this principle, what we are doing. So actually, so there are two ways for the delay of the infection. It's impossible to block the infection, but there are two ways. One is more active, so-called suppression, and another just the general meaning of mitigation. But suppression will cause a very big impact of the economy, of course. So, and the mitigation, but owing to its very high reproductive number. So whether the delay, the general delay strategy will be effective or not. So based on the UK, three principles, I don't think it will cause a markedly delay, because so the contacts, close contact have not under the monitoring. So this is in China. So at that time, so some intensive suppression strategy been carried on inside the whole China. So first of all, they announced the lockdown of Wuhan in the 23rd January, because we based on the fundamental point. There's people just said there was an outbreak in China. I think that sentence not that accurate. So that maybe we should say there's an outbreak in Wuhan, China. That's only in the local area. The other places not spreading yet. So that's why, so just lock down Wuhan, don't go to Wuhan, and don't leave Wuhan. And then the government make the public to make the information more transparent. So they need, so all the cities and everywhere, so to announce the real-time number of diagnosed patients. So every day. And the third, that's most important point, is interagency mechanism. That means the terminology. That means you have to take early cell protection, like distancing and wearing mask, and by all the person themselves. And then early detection and early diagnosis. In the early stage in China, the decision of whether this patient had diagnosed or not is not by the CDC, but by the large hospitals. So that's early stage and early isolation. And the real-time checkup in all close contexts, including those without symptoms. So this is something happened on the day of 23rd. So distancing, restrict people movement, and isolate suspected cases, extend Spring Festival holidays, and also delay school opening, and so all the things like that. So what's happening by this very strong action? So actually you can see that's the 21st January. And after 2 weeks, it is going up, new diagnosed patient cases is going up. So within 2 weeks, reaching the peak. So the February 4th, and then the confirmed 3,000, more than 3,000, close to 4,000 every day, new diagnosed patients. And after that, the number is going down. It's going down. And then after 2 weeks, going to the formal level. So that's something happened in this band. So actually, this is another picture. So I just took at yesterday. So that's in China. So after probably just 1 month, it's going to the plateau. So up to now, so about 100 days here. So this is some countries in Europe and in Japan like that. But the very special in the United States is going up from time to time. It's more than 800,000 right now. So cumulative cases. So that's my the so-called 4 early. So that's down to the community level, and then as you say the management about the this is something like I would like to briefly introduce some of them. So this is the first. Usually we use the lepinavir and ritonavir. So as a so-called Calitra for severe COVID-19. So that's in Wuhan. That's with open control study, and in terms of the time for clinical improvement. So by use the 7-category ordinary scale, and it doesn't show any efficacy in Calitra, in shorten the duration or to clinical improvement, and also did not significantly reduce virus load. And this is one test. And the second test is the clinical application of chloroquine. So we had close to 200 participants were enrolled in the study. And the treatment was giving chloroquine 0.5 gram per, so that's so wrong. So twice a day for 10 days. And then eventually now we had reduced the dose to 0.4 twice a day for 2 days, and then for 0.4 grams for another 5 days. But anyway, at that time, the trial is using this kind of dose. So, so you can see, so from our studies being shown, so this is coronavirus. That's a protein, it's called 3CL protein. So it's actually the chloroquine's target in this protein. And then by using this dose and the blood concentration after withdrawal of the days of the blood concentration is close to 1.1 and then gradually decrease. And then this 1.5 is very close to the EC50 of chloroquine against COVID-19, the blood concentration. So in other words, it's high enough to kill coronavirus. So what's the result of that? So the patient with chloroquine group have a shortened time to reach undetectable the virus compared with the control group, 3 days versus 9 days. And by the day 10 and day 14, with a higher proportion of patients have virus RNA returned to negative. This is the data. It's also significant. And the duration of fever significant fever significantly shorter in this in chloroquine group, and no apparent adverse effect in this study. So we had monitoring all the patients' blood concentration, and also that the contradiction of this chloroquine study is basically is towards the patient with cardiovascular disease, arrhythmia, and something in particular, and conducting dysfunctions. So that's the first. And the second will be some Chinese herbs. I suppose in some of the other countries have also used, in particular, this kind of herbs. We call that Chinese as the 莲花清瘟胶囊. This one, we call that LHQW. That's a mixture. So that's use a capsule. So I just show you the results of it. So we have enrolled about 300 patients. So what's the result after the trial? 14 days, and higher overall recovery rate in treatment group as compared with the control group. And this is the data. And also faster symptom recovery in the treatment groups. That's 7 versus 9 days. And higher rate of improvement of chest CTs, scans, here is the higher. And then clinical recovery, so in the treatment group. However, there's no significant difference in converting rate to the severe cases or viral conversion time. So 11-day versus 12-day, that's no significant difference. So in other words, this kind of LHQW was able to treat the patient with mild or non-severe COPD patients. And that's another one is convalescent plasma. There are 2 open trials study. I just show you one in JAMA. So in 5 critical ill patients who receive convalescent plasma. So the donor should be meet this criteria. Convalescent plasma with this specific antibody IgG binding titer should be greater than 1 in 1,000. And also the neutralization titer should be greater than 40. So that's at the end of this dilution titer. So 400 mils, 1 dose. And just show you the result. That's circulation time. So this is over time, the days. So you can, the circulation times getting longer. In other words, so the virus loads are getting lesser. And this is a score, so far scores, symptom score, getting much better. And that oxygenation is getting better and temperature is going down. And this is, and the fourth, so we now widely use hydrogen oxygen mixed gas. So trying to reduce the airway resistance. So we'll use a generator. So very simple, just plug to the electricity link, and then to transform the water into hydrogen and oxygen. And as you know, this is with much lower density with oxygen and nitrogen. It's because hydrogen is the molecular weight is the lowest. So that's, and also the hydrogen can have the capacity to neutralize the free radicals. So we just gave a primary result. So we have 88 patients enrolled into the study. So that's day 1, day 2, day 3 at the end of this study. So the primary endpoint is disease severity improvement. And the secondary endpoint, dyspnea improvement, cough, and chest stress, and chest pain, and oxygen saturation. In the primary result just show the improvement of the severity disease seems to be quite apparent in this kind of patient. Of course, this kind of patient just shows some symptoms of short of breath, not severe hypoxia. So this is something we're just trying to prevent those patients getting into critical ill situation. So seems to be working in this way. It's on the time for collecting the data and also to write the paper. And of course, just lastly, just one point I would like to point it out. So as in biopsy, you can see consolidation of something red and then tenacious lump tissue. So this is of course by under microscopy, microvascular thrombosis, and also the micro versus hemorrhage and a hyaline membrane formation, and also mucus pooling in the alveoli and bronchiola. So this is something, so we use optical coherence tomography to detect the small airways. That means, that means so the less the diameter less than 2 millimeter. So that will be the 7th generation. So we detect this as the patient with some mucus here. So you can suck out the mucus, very sticky, vicious. And then when we make a study and had found the Mach 1 5 times higher than healthy control, and the Mach 5C 50 times higher than control. And this is Mach 1 and the cytoplastic tails fragment also significantly higher. So that's why if we can solve this problem earlier, so we can prevent some of patients getting to the critical ill situation. So that's not for this COVID-19. That's for acute exacerbation of COPD patients. No, sorry. So about pneumonia patients. So large amount of sputum and using high dose of N-acetylcysteine for the lavage. So it seems to be improved the situation, but we have not. It's using that for aerosol inhalation. It shows a significant improvement. That's a data coming out this year. And then we are thinking about the DNAs. So Parmesan is used to treat the patient with cystic fibrosis. Whether it will be available is should be tried. So that's what I had just very briefly make an introduction. So we need to work together. Just one world, one fight. Thank you very much.
Thank you. Thank you very much, Professor Chong, for your presentation. And really, in a short period of time, you've been able to look at various potential treatments, and it's really been very impressive. And of course, at the moment, there are other studies that are coming out from outside China, as the pandemic has now reached Europe and the US. And I think it will be interesting to compare the results of what you found in your studies in Wuhan in terms of treatment compared to what the results are coming out now from Europe and from the US. So I think we should leave this for the discussion, and I'll now pass on to Professor Bayram to introduce the next speaker.
Çok teşekkür ederim Profesör Chung. Şimdiki konuşmacımız Profesör Rongchang Chen. Kendisi Shenzhen'de Shenzhen Institute of Respiratory Disease'de görevli. Shenzhen bölgesindeki COVID mücadelesinde aktif olarak yer almış. Konuyla ilgili olarak başta European Respiratory Journal olmak üzere çeşitli dergilerde yayınlar yapmış bir araştırmacı. Yine Çin Toraks Derneği'nin de önceki başkanlarından Profesör Chen. Profesör Chen bize Çin'de COVID-19 hastalarında non-invazif mekanik ventilasyon tedavisini aktaracak. Buyurun Profesör Chen.
Thanks for the introduction. My topic today will be about the long image ventilation in the experience from China. Majority of the material, the data is from the Guangdong Institute of Respiratory Health, and I'm actually Lan Zhang is my mentor, and he's still leading the institute, and I'm mainly working in Shenzhen Institute. But anyway, and just look at the data. High percentage of the patients are critical ill and demanding ventilatory support, including high flow nasal cannula and long invasive ventilation. And their recommendation from the Chinese guidelines, and including those guidelines for the severe cases, they recommend the ventilatory support and PF ratio between 200 300, high flow nasal cannula, or can be tried in case the PF ratio between 150 to 200 NIV can be tried for 1 or 2 hours, and in case failed, and then intubated. And in case the PF ratio less than 150, intubation was suggested. And there's many questions related to the choice of ventilatory support, and what's difference and similarity between the high flow nasal cannula and long invasive ventilation? What's difference? Indication or indication for NIV was not clear. The application procedure and the response evaluation, the criteria for that is not clear. And in what situation we should switch from NIV to intubations, and also some concern about the safety while the medical staff performing the long invasive ventilations. And here is we took some lessons we learned during the SARS outbreak. Here is the true picture we took during SARS outbreak. It's nasal, mask, and patient can tolerate much better. And in this review, we showing majority of patients have a good response to the NIV in terms of increase of saturation and decrease in short of breath. And 67% of them, and even though they met criteria for ARDS and can successfully manage with NIV, and 33% were intubated. And the overall mortality in Guangdong at that time is the lowest in the world, 3.6%. We compared those have a success and can avoid intubation for those finally intubated. We see the initial response is comparable, but the baseline, lower baseline saturation is more important in predicting the success to NIV treatment. And here's the data. The lower PS rate shows the higher possibility and failure to NIV treatment. In our cohort, 12 of them was intubated. We tried to intubate patients in case the short of breath was not improved. We tried to avoid severe desaturation. So that's the experience from SARS. And this also some experience say in dealing patients with H1N1 infection and ARDS. And this is case we use the nasal CPAP, and then later on improve and discharge. And now the COVID-19, and the Guangzhou Institute of Health is responsible for care of critical ill cases. So totally, the ordinary people will be managed in other infectious hospital, but those severe cases will transfer here, and 17 of cases and 16 of them are a critical ill, one is severe. And during mission, 12 has already intubated, and even some 5 already on ECMOs, and 5 of them on oxygen and not intubated. And we try to analyze these 5 cases. And so far, I discussed with my colleague in Guangzhou last night, confirmed the data again, and 6 already activated. No mortality so far. We still have 2 very severe cases on ECMO, almost for 2 months on ECMO, but still alive, and there's very difficult cases now. And all the 5 cases receive NIV, all recover without intubations. So yes, this is the 2 pictures. The patients using nasal mask ventilations. So let's look at the 2 typical cases. This is case 2, and the baseline PF ratio is 1:8, but after on the mask ventilations, and it's improved to almost 200. So we keep on, and then the PF ratio gradually improve, and it takes a week, and finally the FiO2 decrease and successfully wean the NIV and discharge home. Another typical case is the case number 5, admitted to ICU with PF ratio 189 after NIV 2 hours to 250. And you can see the curve, and even at the beginning improve, but as the disease progress, will be deteriorating at some time. So you see the image, and then later on, we keep going on for 10 days, and later on the image clearing, the PF ratio improving, and the FiO2 increased to cope with the deterioration, and later on decreased, and the patient was finally discharged from the hospital without the intubations. So we put all the 5 cases together. The baseline, the PF ratio varied. The lowest 128, highest is almost 300. For this mild case, we use only CPAP, and for the other 4, we use BiPAP. And here's the FiO2 and the pressure we use. I think that the key message we use continuously without interruptions. In case some patients they cannot tolerate, and for some patients can use the mask and keep on eating. In case they cannot eat while they are using the mask ventilations, we would put a gas tube to ensure feeding, rather than to interrupt the treatment. I think that's we have many experiments in this. In case you have to improve and stop for eating or something, the separation will deteriorating again. So, and compare with because there's no multi-center randomized controlled study at the moment. But Guangzhou try to use NIV, and our mortality is lower than the reported in other cohort. But one of my colleague, he went to Wuhan, worked in the Wuhan hospital to take care of severe cases. This is this picture he sent to me, and very often they still very severe cases still using NIV in the ward rather in the ICU because the limitation of the situations. So in Wuhan they use a lot of high flow nasal cannula rather than NIV, and they will titrate the FiO2 up to sometimes 70, sometimes 100% oxygen. They cannot maintain the saturation, then switch to NIV. I think that's too late. That's why all majority of the doctors in Wuhan should consider NIV. The successful rate is very, very low. So that's I think, and the situation. I think in case the patient is in these severe situations, we should intubate the patient rather than try NIV. So that's a concern about the safety of the doctors in case we are well prepared. So far, there's no case was infected during the performance of NIV at the moment. So we suggest use a filter to avoid the dissemination of the droplet and virus and protect the medical staff. We also have a mask which can enable us to perform bronchoscopy and also perform intubations during the long invasive ventilation and with 100% oxygen to guarantee to avoid desaturation during intubations. The summary, actually, we don't have enough scientific evidence to support the use of NIV in COVID-19, but the experience from Guangzhou team is promising. I think we need some investigation on what's the criteria for selection of a high flow nasal cannula or NIV, and the procedure we should use, and the indication for switch from NIV to intubation. The criteria we don't know yet. So there's many questions demanding further investigation and better answer. And thanks for Lanshan, the whole team, and providing all the information, and that's all for me. Thanks.
Okay, thank you very much, Professor Chen. We will have questions at the end of the third talk. So now I'd like to switch to introduce our third speaker. Şimdi üçüncü konuşmacımızı sizlere sunmak istiyorum. Dr. Christopher Kui, University of Hong Kong Shenzhen Hospital'da, yine Londra'da da Royal Free Hospital'da kendisi görevli. İki hastanede de görevli olan Hui, salgın başladığında gönüllü olarak Shenzhen ve Hong Kong bölgesinde olarak 10 Ocak'tan beri COVID mücadelesinin içinde aktif olarak yer almış. Daha önce havayolu hastalıkları ve inflamasyonu konusunda çalışmaları olan Hui, şimdilerde de enfeksiyon hastalıklarına odaklanmış durumda. Doktor Hui bize konak immün yanıtı ve akciğer hasarının tedavisi hakkında bilgi verecek. Buyurun Doktor Hui.
So thank you very much, Professor Bayram, and I'm delighted to be given this opportunity to share the stage with Professor Zhong Nanshan, Professor Chen Rongchang, and Professor Ken Fan Chung, and our esteemed colleagues today. I'm delighted to be able to share some of this information with our colleagues and friends in Turkey. So the title of my talk today is Host Immune Responses and Lung Damage Induced by Severe COVID-19 Infection. So just to recap a little bit, my background is in Hong Kong and in Shenzhen, where I have been working for the last 8 to 10 years. And we have been, as you know, involved in this fight against COVID since about January this year. And then in the more recent weeks, I have moved to London to base myself with NHS England under direction of colleagues and advisory bodies. We work together with colleagues in Europe to see if we can work out better solutions and treatment management plans for these patients, particularly looking at the severe cohort on our critical care and intensive care units. So as you know, from January, we are all seeing the same clusters of cases everywhere in the world now. This is truly a global pandemic, and these CT scans and images, the characteristic ground glass changes, will be familiar, no doubt, to many of our colleagues in the audience today as well. The problem, of course, is that the spread of this viral pneumonitis and the alveolitis, as has been described by Professor Zhong and Professor Chen already, extends very quickly across the lung to cause deterioration of gas transfer and the loss of the DLCO, which can lead to life-threatening mortality and morbidity if intervention isn't achieved early. And so I'm a big advocate, as Professor Chen and Professor Zhong are, of early intervention with critical care support. So we know from SARS in 2003 that early intervention with both non-invasive ventilation and intubation ventilation is critical to the survival of some of these patients. We think this is in the range of about 15% or 10 to 15% of patients who will require sort of high-level support at the extreme end of the medical spectrum. And here on the right-hand side, you can see our colleagues. This is a rapid sequence induction intubation. And you notice as they go down, they've got the endotracheal tube over the scope with a guided intubation, but also a biopsy forceps down as well, so that we can get samples at the same time, all in one go. So what do we know so far about the SARS-CoV virus? Well, we know it enters via the ACE2 receptor system, and that the infection can be roughly divided into 3 stages. I thought these 2 studies by my colleagues in Wuhan were exceptional. In the early stages of the outbreak, they described the clinical characteristics in a lot of detail and provided us with a lot of relevant information. They've also classified the SARS-CoV-2 infection into 3 stages, and we'll recognize this as the sort of 80 to 85% of patients in the early stages who have either an asymptomatic incubation or the so-called asymptomatic transmitters with non-severe symptoms and the presence of a detectable virus load, but later developing stage 3 disease in certain patients. About, again, in most populations, we think 15% of the population of affected individuals who may go on to describe or develop severe respiratory symptoms with a high viral load, a cytokine storm, acute lung injury, ARDS, end organ failure. And we see this now more and more. On our critical care unit here at the Royal Free Hospital in London, we've seen up to 30% of patients requiring, developing acute kidney injury and requiring CRRT or hemodialysis as well. During the incubation and non-severe stages, a specific adaptive immune response is required to eliminate the virus or to preclude disease progression. So we know that the body in certain individuals, in the majority of people, have the ability to fight off this virus via the specific adaptive response. However, we know that genetic differences in both the innate and adaptive host immunity are well known to contribute to individual variations in the immune response to all pathogens. Now, this is something that is new to us all as respiratory clinicians. My own background is in airways disease, in the study of asthma, and like many of my colleagues, colleagues here. But I think we need to start to think about the immune response in a slightly different way now. So what do we mean by early stage versus severe? Well, if you look at the early stage, this is from work done in China as well, and our colleagues from across China have been collecting samples from deep lung sampling, either by bronchoalveolar lavage or deeper lung sampling by aspiration. And you can imagine these are quite high-risk procedures to the healthcare workers, and I really do have huge respect for our colleagues who undertake these procedures at risk to themselves. But the information that we've got, as has been outlined by Professor Zhong before, is that we know that there's an upregulation of MUC1, MUC5B, and so on and so forth. But we also have markers now of the severe stage cytokine storm. So we are seeing an increased signal of hyaluronidase, Has2 inhibitor, activated MSCs, and so on and so forth, which may be the release or the loss of control on a sort of spiral system where increasingly severe inflammation is developing and out of control in those areas of the lung that worst affected. So we know that when the immune response is impaired in those who are immune compromised, perhaps people who are post-transplant or who are on long-term steroids, that the virus will propagate freely and lead to acute injury of those lung tissues, of those tissues, especially in organs that have a high ACE2 expression, such as the intestine and kidney. We also know that damaged cells will continue to release pro-inflammatory cytokines in the lungs that is largely mediated by macrophages and granulocytes. So in conclusion, we know that the lung inflammation remains the primary cause of the life-threatening respiratory disorders that we see at the severe sort of ICU stage of the disease. So when we look at the most severe, most vulnerable patients, we have to think about lung inflammation being the cause of death rather than just the virus itself. And so we are now looking at different ways of suppressing inflammation and managing these symptoms. And we have a little bit of insight into that. So since I've been in London, I was working in Shenzhen through January, February, and March. And then in late March, I received a call from NHS England and my colleagues back here. And we've examined through the UCL Center for Immunology this question here, which was posed by Professor Helen Mackinnon, my colleague. She asked, can experience of cytokine inhibition in other diseases help us to identify the potential for therapeutic targets in COVID-19? And this, I think, is a very relevant question. Now, we know from the current studies across China and across the world that Kaletra, hydroxychloroquine, and many of our existing sort of hypothetical strategies are yielding results that are less than satisfactory in the context of early clinical trials. Now, obviously, in the early days, we were using these agents as well. We struggled a little bit because we had very little other options, as I know many of us face now as well. But we did have to try to consider all the available treatment options available. So what is the other half of immunity? Well, we know that the immune is made up of the inborn immune system. This is germline encoded. It's encoded in our genetics. It's always present. It has an immediate response, and it has the same response regardless of the stimulus. It doesn't learn, and it doesn't have a memory. It doesn't adapt. The adaptive immune system, this is what we adaptive immune exposure to the pathogen, and this thing we were hoping to see in COVID infections. It can take several days to several weeks to develop. It is IgM and IgG mediated, and it develops antigen-specific responses from a bank of immunological memory that is designed by the body to target the antigen. And we have many models of this. So we know from systemic autoinflammatory diseases that mutations affecting the innate immune response can lead to sterile inflammation. So we see patients in conditions such as adult Still's disease or familial Mediterranean fever, or in Schnitzler's disease that have a HLH, etc., where you have sterile or apyogenic non-bacterial inflammation. In these conditions, there is no class 2 HLA association. There is often no gender predisposition or autoantibodies or antigen response. And these are systemic autoinflammatory diseases. The acquired forms are also recognized, and these may be the so-called experiments in nature that give us insights into the mechanisms that regulate the inflammation. So with the cytokine storm that we are seeing, this is life-threatening. We know that it is excessive. It is driven inflammation by inflammatory cytokines, pro-inflammatory cytokines, and it causes sustained fever, hyperferritinemia. I've seen patients with ferritins in the 6,000 range, pancytopenia, which may be worse than just the lymphopenia that we initially with the viral infection, fibrinolytic coagulopathies. We've mentioned hyaline thromboses. I've seen a lot of patients with subsegmental pulmonary emboli on CTPA that lead to end organ failure, dysfunction, and failure ultimately in death. We know that these conditions also exist in many other patients, such as HLH and hyperferritinemic hyperinflammation illnesses. And there have been scoring systems developed before by mostly rheumatologists and hematologists to look at this. The one I've shown you on the right-hand side is the H score, which was published in Rheumatology in 2014 and is a standard guide for inflammation in rheumatology. With the cytokine storm, when we start to think about this, there are many potential targetable agents. And I know across China, many of our colleagues have been working very hard to study IL-6, tocilizumab as a target. We are now experimenting in London with IL-1 and IL-1R inhibitors, anakinra. This is a recombinant IL-1RA inhibitor. We also have access to canakinumab, anti-IL-1 beta receptor inhibitor, the monoclonal antibody, and rilonacept, which is an IL-1 trap inhibitor. And these are target inhibitors that we're looking at, but we're not sure if they work individually or independently of each other, because as you look at the cascade of inflammation, what we do know is that the cascade is turned on by multiple switches. So the concept I want you to go away with or to bear in mind is one of a piano keyboard. In China, we have the guzheng, which is a classical instrument. Rather than playing one note at a time, we may have to find the magic combination where you're playing many notes to make the music or the sequence of second order consequences clearer or controllable. And so we're looking at chords of control. In terms of other targets, we're looking at INF interferon gamma, Janus kinase inhibitor, baricitinib, and also anti-TNF as well. Now, I spoke to my colleague, Professor C.S. Lau at the
Hong Kong'daki tıp akademisindeki meslektaşımla konuştuğumda kendisi SARS mücadelesinde de önemli bir kişiydi. Oldukça ilginç çalışmalar
of severely ill patients, and I think the conclusion was that the problem is there is a significant downside risk to using these targetable agents in the context of someone who's very unwell on ICU. And so we have to be very careful when we approach these we are setting up clinical trials. The first of our targeted IL-1 receptor clinical trials will be starting next week in London. And I can share with you that we already have N=3, N=6 on each of these agents, where we believe that the early stage data shows some improvement. Just to give you a snapshot, these are patients with CRPs of over 600 to 1,000 when they come in. The ferritin was 6,000 or 7,000, and the D-dimer was approaching 7,000, 8,000 as well. So these were people who were very unwell. The CT shows very florid ground glass changes, which are very widely distributed. They have saturations of 90% on FiO2 of 80 or 100% oxygen on ventilator. And so they are really the sort of sharp end of the wedge where we had very little other options. So I'd like to just focus on the last 5 minutes, or last 2 minutes rather, on IL-1 and anakinra. We've talked a little bit about this. So this is a recombinant form of the endogenous IL-1 receptor antagonist, IL-1RA. It's a non-glycosylated 76 amino acid chain, which mimics IL-1RA in blocking the 1-beta binding point. It lasts about 4 to 6 hours. It's administered daily, and it's currently licensed in other conditions such as rheumatoid arthritis with methotrexate, in CAPS, and in Still's disease. It is a small molecule that has renal clearance, and injection safety is good, but it does have some site safety reactions with a minimal anaphylaxis or neutropenia signal. It is thought to be safe at higher doses, up to 10 milligrams per kilo per hour in phase 1 studies, but we haven't gone that high. So the dose I have at the moment for for example, a 70-kilo man on our ITU level 2 unit is about 200 milligrams daily, once daily. So anakinra was first approved in the US in 2001. It's not a new drug. In Europe in March 2002, it has been used. And there are multiple studies that you'll be able to look up in the literature that's published. About 900 patients were studied with severe sepsis on ITU by Fisher in JAMA in 1994. And this showed neither benefit nor harm. But the problem with this was a very large study, very ambitious, but it didn't separate the subset analysis by looking at what type of sepsis the patients came in with. So I don't think the signal on benefit there is very clear, because they basically put 900 patients sequentially on ITU together, and they didn't break out the phenotypes that they were looking at adequately. So in terms of the retrospective reanalysis, we found 53 hyperinflammatory patients did respond quite well to anakinra with death of 0.28. And so this was re-examined in critical care medicine in 2016. What other evidence do we have? Well, the drug has been licensed by NHS England since 2018, so it's only been about 18 months that we've had access to this drug. It's very new to us. It was originally commissioned as a first-line treatment for Schnitzler's syndrome and for familial Mediterranean fever, hyper-IgD syndrome, and adult-onset Still's disease, where it's still used as a secondary refractory line of therapy or a third line of therapy to those who are non-responsive. It has also been used in meningitis caused by rare genetic mutations, pyogenic meningitis. It has been used in pregnant mice with Zika virus to good reasonable effect at Johns Hopkins University. And it has been used to treat breast cancer metastasis and the inflammation in the bone at Manchester. So there are some analects of evidence and some indications on a very broad range for the use of anakinra in different areas. And it is thought that this has regulatory control on the overall inflammation pathways. The problem, of course, is that we don't know if this works independently of other cytokine pathways or whether it works in conjunction with them. So in summary, there's only too little data for anything other than speculation right now. Unfortunately, multiple targets of a variety of cytokines are available to us, and I would highlight that IL-6 is not the only potential target. IL-1 is a plausible target to me, to our unit at the Center of Immunology. It has good safety data in ITU settings. but the evidence of benefit in hyperinflammatory states is not proven. It is a short-acting agent, and we've been using it with some confidence now for up to 4-week intervals. So the patient I described to you, the 3, have been on our intensive care for 35, 36 days, and they are recovering. So there seems to be some plausibility in use of these agents. However, we are unclear about the duration, the choice of target agent, and the sequential order or combination advantages of these drugs. And it may be that as we become bolder, we may be combining IL-1 with IL-6 in lower doses to try to modulate the cytokine storm that is associated with the lung injury and acute lung inflammation of COVID-19. In terms of anakinra specifically, the outstanding questions are patient selection, of course. How do we select the best patients or the most appropriate patients with the worst or most significant inflammation? What are the prognosis and treatment responses and the timing? Are we aiming to treat on the trajectory of the upstrike of the inflammatory response, or are we trying to cut off at an arbitrary threshold after the apex or the peak of inflammation has already happened? In terms of dosing, we give anywhere between 1 and 10 milligrams per kilo per day. As I said before, we're at the conservative end of the spectrum. So for a 70-kilo man, I'm using about 3 milligrams per kilo per day at the moment. This gives me a dose of 200 milligrams per patient per day. We're using it subcut or IV, and we're using a supervised continuous infusion or intermittent dosing. I note from the questions popping up on my screen now that there are people asking about remdesivir. We have used this as well, but the early clinical trial data from Gilead at the moment on the global study that we're all participant to does not appear to yield significant survival or outcome advantage. I think this is very early data at the moment, and I don't think it necessarily reflects a conclusion about remdesivir, but we do need to think about it a little bit harder, as we do with hydroxychloroquine and Kaletra and other treatment strategies. I will add that we have also used in specific cases low doses of steroids for short periods of time in patients who haven't developed bacterial infection. And we found that works reasonably well, although we accept that steroids are a blunt instrument and that they should not be recommended for all COVID patients. And I need to be very clear about this. This is not appropriate for mild or moderate disease. In the intensive care setting, we have considered the use of prednisolone or hydrocortisone on a limited basis to help damp down the most extreme inflammation. And I think it goes down the same route of arguing that it is the significant inflammation in the lung that causes the most damage and the most mortality at this severe end of the spectrum. Thank you very much.
Çok teşekkür ederiz Doktor Üye. Bu güzel ayrıntılı özellikle mekanizmayla ilgili sunumu için. Hocalarımıza Profesör Zhang, Profesör Chen ve Doktor Üye çok teşekkür ediyoruz. Çok sayıda soru görüyorum ekranda. Sevgili Cüneyt arkadaşım da bana yönlendirmiş durumda. Şimdi bu soruları bütün konuşmacılarımızla olabildiğince tartışalım istiyorum. Vaktimiz kalırsa başka ekstra sorular olursa alabiliriz. Yine konuşmacılarımız dilerlerse vurgulamak istedikleri noktalar olursa sorulardan bağımsız olarak tabii ki vurgulayabilirler. İngilizce sorulmuş bir soru. Bunu doğrudan İngilizce okuyayım isterseniz. Bilmem konuşmacılara transferi nasıl olur? Soru, why did China change the case definition causing the spike in the number of cases in mid-February? Sorry, could you understand me? I directly read it in English.
So, Masan, are you asking me?
Yes, please. Yeah, I think it's, well, I mean, any speaker could answer, but I think...
Would you please repeat your question? Would you please repeat your question?
Okay. Yes. He is asking, or she's, why did China change the case definition, causing the spike in the number of cases in mid-February? Was there a case definition, the change in case definition? Could you understand?
Oh, I don't think that's a change of the definition. Are you talking about the why? That's a peak going up.
Yes,
and the
yeah, I think it's that one. Yeah.
Yes, yes, I know that. So that's because a huge number of Wuhan is defined as suspected patient, because there's no enough equipment available for the detection of whether they can be diagnosed as having COVID-19 infection or not. When those patients receive the test, and then the majority of quite a big number of these patients receive this test, and that will be given and definitely diagnosed. If the RNA PCR is positive, they were diagnosed as having COVID-19 infection. That's why. So the majority of them had been make a diagnosis. They are or they are not. So that's why the peak is going up. So that's nothing changed of the definition.
All right.
Am I all right for the answer? Yes.
Yeah.
I would also thank you, Professor Zhong. I would also like to just add that there's a paper here that answers this question very nicely that I'm just sharing on the screen now. The effect of changing case definitions for COVID-19 on the epidemic curve and transmission parameters in mainland China. This is a modeling study that was published this week in Lancet by Ben Cowling and Gabriel Leung, my colleagues at Hong Kong U. I think the conclusion is very important here, and I want to be very clear about this. The case definition was initially narrow and gradually broadened to allow the detection of more cases as our knowledge increased. We were working under very difficult conditions. I think you can understand now from a global perspective that some of our colleagues and centers were working under very difficult conditions, and there was a particular consideration that milder cases needed to be taken into account. And this was the case definition change that you see. There was no difference in the numbers per se. The statistics were all reported accurately. The problem was that with milder cases and those without epidemiological links were then taken into consideration. The case number increased in February, and this was just a new definition reflected in the reproductive number. Thank you.
Yeah, I agree with that, Chris. So because we have found some of the patients, they so-called asymptomatic. Actually, they have a mild symptom. For example, fatigue and muscle pain, and then usually have some mild fever, very mild fever. They are not thinking about they are having symptoms. You're right. So this is something I think. So actually, some of the asymptomatic patients, actually at a big number, they actually have some mild symptoms. So they are not asymptomatic. I agree with that.
Thank you.
All right. Okay, thank you. Yeah, another question is about the in definition of cases. I mean, were all cases all PCR positive, and the clinical radiologically proven cases were they also defined as COVID cases or not?
Yeah, I think if
there's a problem really in Turkey as well.
Yeah, I think once the patient should be make a diagnosis, definitely diagnosis, they must have the PCR positive. But in other words, so the PCR negative in just one test, it doesn't mean it's correct or accurate. So they should receive, perhaps if they have symptoms, they should receive 2 times or 3 times PCR test. Sometimes the sampling and something, there will be some mistakes. So sampling, different sampling, we have a 30% different. So I suppose the majority of in China, I think nasal swab is much better than throat swab. Of course, nowadays in Hong Kong, I think, Chris, so you have been using saliva. I mean, not saliva, actually the secretion in the throat. So we are trying now to make a comparison of that.
Right. So I think you mentioned that you take samples at least maybe twice or 3 times for PCR. Because
Yes.
it's such a question. And they're asking the PCR positivity in China, I mean the rate of PCR positivity.
Yes, only in those patients who have symptoms. We'll repeat once again. And some of them recently, if we have some suspicion of this, we were doing some serum antibodies as well. So usually we have a double check of this suspected patient. A PCR on the one hand side, and other one is IgM or IgG together to make sure whether it is really diagnosed as having COVID-19 infection or not. So double check is much reliable.
Right, right. I mean, is the double test common in China? Because in Turkey, we started, then it is thought to be having low sensitivity, then it stopped. So there is an ongoing debate really on anticore testing, I mean IgM or IgG testing.
Yes, I think now, I think in the majority of people inside China, they're suspected. They have no immunofunction against COVID-19 infection. It doesn't like people like special in Wuhan, that their background of IgG is much higher than the others. Of course, I would suspect in Europe or in the US, the survey showing that maybe they are doing the survey right now. Now China had decided to have a general survey in some specific groups, like in staff and some school children and some other, both PCR tests as well as serum antibodies. Yes.
Right.
We're starting right now.
Okay, thank you. So there is a question about the side effects of chloroquine. Is asking that there are reports about high number of serious adverse events that are associated with use of chloroquine. But in Turkey, we don't observe such a high rate of arrhythmia or other side effects. And he is asking whether you think that there is a difference in the virus genotype, or can there be an effect, I mean, or a genetic maybe factor within the Turkish population or Chinese population, vice versa?
Well, I perhaps
because chloroquine is quite commonly used in Turkey actually, and he is right. We don't have much observation about side effects of chloroquine.
So at the very beginning, we are very much concerned about the side effect of chloroquine. In particular, in dealing with patients with cardiovascular diseases. In those patients with the QT prolongation, this kind of patient, that's a contraindication for the use of chloroquine. So we are not using this guy in those group of patients. So during our study, and the whole study, we are very much aware about the adverse effect of a cardiovascular function. So in particular, conductant function. So far, we didn't find any patient had such a severe side effects, just like some report from Brazil and some others. They found some elderly patient had a sudden death and some others. So that's only one paper showing from the New England Journal of Medicine in the year 1988, 98, I suppose, or 95, not 94. They have made some analysis about the patient who commit suicide by taking chloroquine. So the dose will be very high, such as and the blood concentration will be as high as 25 micromole per liter. I think that's we have monitored the blood concentration. It's only 1 to 1.5 micromole per liter. I don't think that will have any harmful effect for the ordinary people, except for those with QT prolongation.
Right.
Thank you.
Okay, thank you.
I would just add, I think
please.
I fully agree with what Professor Zhong has just said, and I would point the audience in the direction of the JAMA paper published yesterday from the Brazilian study, as Professor Zhong mentioned already. There were 440 patients enrolled in this study, and it's the first randomized controlled trial that separated patients into high dose and low dose groups. From the early data that I've seen so far, in the outcomes after 28 days, we have to be very clear about this. After 13 days, 6 of the 40 patients in the low dose group had died, compared with 16 out of 41 of the patients in the high dose group. So I think, you know, this correlates with what we're saying in terms of the safety profile. Should consider always that the approach is with a lower dose where appropriate, where it's safe to do so, and to consider very carefully the side effects associated with hydroxychloroquine as well, especially those with underlying heart disease or dysrhythmias, arrhythmia disease.
Okay, yeah, thank you. So the other question is about the
So this is why we had changed the dose, reduced the dose. The first and second days of 400 milligrams. I was talking about the chloroquine, and from the Massachusetts General Hospital, the guideline also mentioned about the dose, so hydroxychloroquine. So that's 400 milligrams twice a daily for 2 days. Another 5 days, just 500 milligrams once daily. So it will be much better.
Yes.
Right. Okay, thank you. And another question is start with a comment saying that it's outstanding the way you managed infection spread in a very short period of time. And I'm curious to know, how did you choose the drugs at first? Because no studies made before and the new infection is existed. It seems that any drug you tried worked out pretty well. Are there other alternative drugs that you tried but that didn't show any effect? A comment and question.
So excuse me, so you mentioned about secondary infection?
No. He's asking whether you tried any other drugs right from the beginning of the infection that did not work. Because since it was a new infection and we didn't know what drug to use, what drug will work, but the first choices of chloroquine or other drugs, he's saying that seem to work very well. But whether you tried any other drugs that didn't work?
No, we had not. In terms of medication, drugs, no, not yet. Remdesivir have been tried, but right now, Christopher had mentioned, even in China, I don't think that's a very specific targeting therapy for remdesivir for this kind of diseases.
Okay. And another audience is asking about your experience with oral N-acetylcysteine. Did you use it, and do you think that it may work? Especially, you know, if you could give orally.
What kind of drugs?
N-acetylcysteine. N-acetylcysteine.
NAC.
NAC, yes.
Oh,
NAC.
okay.
Yeah,
Yes.
yeah. Sorry for
this
that.
is a kind of so should be trying. So you should use a high dose of it is said. Well, we use 600 milligrams 3 times a day in the prevention of acute exacerbation of COVD. It works in that way. And then we have been doing some laboratory study showing that because the hydroxy sulfide group, it's capable of eradicate the free radicals.
Yes.
That's why it seems to be working, and also in addition to the mucolytic action.
Okay.
So it's worth trying. So, but it's better to use in the early stage.
Okay, yeah, thank you. Another audience is asking about your experience with favipiravir. I mean, how was it? That's his question. I mean, your experience with favipiravir in patients. Favipiravir. Shall I?
Yeah.
Can you
referring to the Japanese study?
Yeah, the Japanese drug. Yeah.
From Fuji, I think.
Yes, I think so. Yeah. And I think it was announced.
We haven't had any experience of using this in our units.
All right. What about in mainland China? Professor Zhong, would you like to say something?
Okay. What kind of drugs? Can you say again?
It's you mean the pirfenidone?
No. Favipiravir. How do you? I don't know whether my pronunciation is right. Fan, do you?
Yes, favipiravir. This is the drug developed by. Is it by Fuji company in
yeah,
Japan?
I think it was Fuji. Yeah.
An antiviral. Chris.
Oh. Favipiravir, right?
No, I can only comment on what I've read as well. Avigan, that's right. The drug is new. It's not available in every market, and I think we probably have some work to do to get it licensed and approved here in the UK as well, and in China, in Hong Kong.
Oh.
Yeah, because I think now our Minister of Health imported some from, I guess, from China, and they use especially for critical patients in ICU. And there is some sort of experience that it works pretty well. I don't know, that's my perception that I hear from my colleagues.
Okay. Okay. I'll try to find it out. Thank you.
Right, okay, thank you very much.
Right.
And we have, one of my colleague is asking whether you use helmet in ICU, I mean, during a non-invasive ventilation. Perhaps this question is for Dr. Chen, Professor Chen.
So,
the helmet for
non-invasive helmet is available in majority the hospital in China. Only one center in Zhengzhou, they try to use in ARDS, but not this time. So there's limited data regarding to helmet non-invasive ventilation in China. Right. Okay. Thank you. And the question is about healthcare workers infected. He's asking how many healthcare providers or workers were infected, especially in intensive care unit, or died in China. I mean, are there such statistics? I guess there are. So, because it's a problem nowadays, especially in Turkey. So we are always arguing about the prevention and
preventive equipment, which is nowadays a problem, I guess, everywhere. So how was it in China?
Well, I think altogether in China, there are 1,600 medical staff being infected. Yeah, being infected, but the almost the mass majority, as in Wuhan, at that time is the very beginning is really loss of control. Some of the medical staff with very poor PPE said that they were impacted, and after that, I think so about more than 40,000 people, the medical staff going to Wuhan to support them. They can have a very well PPE, so good equipment, protection. So since then, I have not heard any information about the infection, the transmission to the medical staff since then. I think the PPE is really important.
Yes, and we could see from TVs, from the press, how sort of tough really those measures were taking in China. So this is really good.
Right. Fan, I suppose I have to go to another meeting. So that's the day of the 8:30. So
okay, I think most questions for you that we already asked, because I guess the audience started from the first talk, to the others. So I think you could go, Professor Zhang. Thank you very much indeed for your participation, for your contribution. Thank you so much.
Thank you.
Bye.
Thank you, Professor Zhang.
Okay, so
we are rapidly approaching the end of the meeting.
So
are there any other questions, Hassan?
Yeah, there are many questions, in fact, but I'm just trying to. There is a question for Professor Chen. The audience is asking whether you apply high-frequency ventilation, jet or oscillatory, for the treatment of acute respiratory distress syndrome, ARDS.
Well, yeah, thanks for the question. Actually, for jet, we used a lot in the 80s. That's 30 years ago, but we stopped using that because the airway secretion retention is very common, and for the oxidation, we only for children, the infant, it's more commonly used, but for the adult, it's already used in China. So we think that it's not as effective as with the lung protection strategies.
Okay. Yeah, I have actually last question. I was going to, Professor Zhang left anyway. So he was saying that they used hydrogen peroxide, which is a strong oxidant, really. I mean, in the lab, we use it to induce oxidative stress. I'm a bit surprised that it really worked, especially in ICU patients. I mean, how do you explain this, Fan, perhaps?
Sorry, Hassan, I think what Professor Chung is alluding to is a mixture of hydrogen and oxygen.
All right.
And the idea is that the work of breathing would be much less, because those using hydrogen mixed with oxygen, you lighten the gas. So it's not hydrogen peroxide.
All right. So it's not in form of hydrogen peroxide. Okay. Yeah. Thank you.
I mean, it's like using helium.
All right.
Yeah, the idea of using helium for ventilation.
I think, and further on that, and because the low density of hydrogen, and also the hydrogen have some anti-inflammatory properties. But there's a lot of published data on the lab, but for the clinical trial, and it's something is going on. But anyway, I try it myself. It's well, it's easily used, and there's some patient the feelings and some comfort while inspiring the mixture of hydrogen and oxygen. It's easy to use. I tried it myself. It's but the efficacy need to be determined.
Rongchang, is this machine available outside China, or is this a Chinese machine that has?
Oh, it's Taiwan.
From Taiwan.
Mainly in Taiwan, but there's several trials going on in mainland China. So yeah, they try COPD and also trying for the COVID-19. I think I'm anxious to know the outcome, but anyway, it's easy to use. I tried it myself.
All right.
Yeah.
That's very interesting. Yeah. Well, there are, I mean, many questions, but of course, the time is run out now. Do you mind if that we can collect these questions and email to you, because that's what we do at the end of our webinars. We try to respond all questions. Would that be possible?
Yeah, for me, it's fine.
Yes, of course. Thank you, Professor Bayram.
Yes.
Okay.
Before we go, Hassan,
yeah, please.
Possible in a few words just to give us a situation in Turkey as it is at the moment.
Right.
COVID-19.
Right. Okay. Well, I mean, we still have patients, and some people think that we are in plateau, but still, especially the physicians who work in the field think that the number of cases is still rising.
Yes.
So we are not sure about the plateau.
The moment you're in a state of lockdown and the social distancing.
Yeah.
And,
yes.
And widespread mask wearing. Is that correct?
Yeah. Yeah. It is compulsory. So if you are in the street, you have to wear a mask, and in hospitals everywhere, of course, we have to do. And I mean, so far our health system is capable of treating all cases. So the capacity of hospitals, ICU units is dealing very well so far. But of course we have physicians, healthcare providers who are infected. Some of them lost their lives. This is the the problem with healthcare workers.
Yeah.
So I mean, it seems at least not out of the control. I can say that, but it is still too early, I think, to say that it is totally under the control. Yeah. We are, I think, in between.
I know we're running out of time. I just saw a comment coming in, which is an important one. I think perhaps the members of the panel could answer this one. This is related to anticoagulants and the importance of anticoagulation, and maybe we could get an advice from Rongchang and also from Chris before we close, because it's a very important issue. Perhaps we should answer that.
Yeah. Yes.
And from China, there's a panel of doctors. They work out the consensus and suggesting in case subjects have is critical ill and have elevated D-dimers, they would suggest in case no contraindications and suggest prophylactic dosage of anticoagulant.
And Chris, do you have anything to add to that?
Sorry, I think that overall, in terms of the sort of treatments and the management that we've seen so far, this is, you know, I think this, I'd agree with what Roshan said, that really we have to be just a little bit sort of we consider to follow up and then to see how they go.
Right.
Hello.
Thanks very much.
Okay.
Hassan?
Yeah. Thank you all so much for contributing to the meeting, for your participation. We greatly appreciate it for your sharing your experience with us, with our members. Thanks so much. I would like to pass to you, Fan. Would you like to say something?
Yes. I'd like really to thank our speakers today, and I think we really had a very good idea of you know, the experience they've had and some of the ways of treatment and the experiences of treatment. But I think we still need to learn a lot, because this is a new disease that we've only learned to know about for the past 4 months. And still at the moment, we're still unclear about what is the right treatment. And also at the moment, there is this big issue as to how we're going to try and cope with this virus over the months to come, and indeed possibly over the years to come. And so all this work that is being done at the moment to look at the acquisition of antibodies in the general population and the possibility of developing a vaccine is something at the forefront of our battle against this virus, and together with the development of really effective drugs to treat patients who will keep getting this infection, and who those patients who have a very severe response to this virus. So I hope that our Turkish doctors and friends have benefited from this webinar. And as Hassan has said, the remaining questions that have been posed by our viewers, I think will be answered by our speakers. So let me again thank Professor Chung, Professor Chan, Dr. Hui for their participation today, and thanking the audience also for their participation and for the questions.
Thank you.
Çok teşekkür ederiz Professor Chung, Professor Chan, Professor Hui, and Professor Zong. Toplantıya hazırda başka toplantısı olduğu için ayrılmak durumunda kaldı. Hepinize çok teşekkür ediyoruz tekrar Türk Toraks Derneği adına. Bütün katılımcılara da sorular için, katılımlar için, katkılar için çok teşekkür ederiz. Hepinize.